So today's starting topic is Niftp. Is Niftp considered a thyroid cancer? Niftp follicular uncertain malignant potential, high HTT or pathological diagnosis with very low malignant potential. Hence, don't be aggressive like doing completion thyroidectomies or doing lymphadenectomies and post-completion thyroidectomy going for any radioactive iodine therapies. This was backed up by the Niftp et al. In 2016, where the initial definition and validation was done for this. So what Niftp et al. Says is he has initially coined the term Niftp for this non-invasive encapsulated follicular variant of PTC, and he made a study. Okay, in his study, it was a multi-center international study with 13 institutions and 5 countries, where the aim of the study was to reduce the over-treatment of the indolent tumors. The cohort size was 210 patients with a non-invasive encapsulated FEPTC compared with 352 patients of invasive tumors. So there are about 13 years of follow-up, and that's the median follow-up. And pathological re-review of the tumors with strict criteria was applied. The criteria applied was the tumor should be encapsulated, and the pattern should be follicular growth pattern without any papilla or true papilla. The nuclear features of PTC like enlargement, clearing, grooving, pseudo inclusion should be present. No capsular or vascular invasion should be present. No somoma bodies, no hematotic count, no necrosis, no tall cell, clear cell, hobnail cell, columnar cell variant. Okay. The results of this study are there were zero recurrences or death after surgery of lobectomy or total thyroidectomy during follow-up in cases of encapsulated variants, and no distant mets also. In the observational group of in invasive group of 352 patients, the recurrence rate was around 12%, and some of them developed distant mets and deaths also. So what the conclusion of this comparison gave out is Niftp criteria strictly should be applied, and all these Nift tumors which are reclassified as Niftp prevents unnecessary total thyroidectomy, lymph node dissection, RA, and lifelong tissue suppression. The projected to remove the label cancer from around 10 to 20% of the tumors previously which were diagnosed as PTC can now safely be observed. So there was a paradigm shift from low-grade thyroid cancer to non-invasive malignant neoplasms, directly influenced the ATA 2016 and WHO 2017, and formed the basis of first recommendation of ATA 2025, the Niftp 2016. Okay. Once we summarize all the evidences, what has happened after 2016 and who has all done the research regarding the Niftp, uh, and basing on that we'll decide. Okay, Niftp in 2016 first defined the Niftp with T10 210 of non-invasive and 363 of invasive tumors with 11 years of follow-up. Then in 2018 he revised his criteria, eliminating the one less than 1% papilla also, because papilla were correlating directly with lymph node mets. So he said there should be no papilla at all, true papilla. And Zhu et al. In 2018 and 2019, he has included two more categories into indolent group, that is micro Niftp and oncocytic Niftp. And in Rosari and Mora et al. In 2019 summarized near zero recurrence with application of correct criteria. Okay, and Parenti et al. In 2018 said that rare adverse outcomes reported highlights misclassification risk if criteria is not strictly applied. So underscores the need for strict capsule sampling and no papilla. So this should be very important. Strict capsule should be sampled and there should be no papilla as per Parenti et al. And Paja et al. In 2021 showed how pathological criteria affect Niftp. That criteria should be strictly adhered to. Rana et al. In 21 ran a meta-analysis globally and showed the worldwide impact of incidence shift with the adoption and supporting the category robustness of Niftp. And in 2022 finally Cole et al. The trends in Niftp diagnosis and total thyroidectomy rates showed Increased Niftp recognition is associated with fewer total thyroidectomies. That is a real world de escalation effect as per CALI 2022 data. So, coming to the molecular basis of Niftp, these are very indolent because these are RAS like driven tumors. These tumors are RAS driven tumors. About 50% of them carry RAS mutations, some of them carry Paxate PPR gamma or THA-DA mutations. So these mutations mostly favor the follicular growth and not with the papillary features or invasive behavior or extension to the lymph nodes. So combining all these features and adhering to strict morphological features and the Nikifora study followed by the various other studies up to Calais study in 2022 quoted in ATA guidelines suggested that Niftp is a ROS-like encapsulated tumor whose uh, neoplasm, not tumor, neoplasm, whose molecular profile and strict morphology converge on the indolent nature of the tumor. This is about the Niftp.